Imagine a room with 10 people in it. Statistically, 2 or 3 are quietly carrying a mental health condition right now: anxiety, depression, the weight of something they can't quite name. Now imagine that in much of the world, 9 out of 10 of them will never see a professional about it. Not because they don't want to, because the help simply isn't there. That's the crisis. But here's what almost nobody talks about. Across some of the poorest regions on earth, people are quietly building a fix, and parts of it are working. Let's start with the scale because it's bigger than most people realize. Health experts estimate that hundreds of millions of people around the world live with a mental health condition. One global estimate put it near 450 million. Mental health is one of the largest health challenges on the planet, and yet, for decades, it has been treated like an afterthought, the last item on the health budget, if it makes the list at all. Nowhere is that gap starker than in sub-Saharan Africa. In some studies, rates of depression run far above the global average, by some estimates approaching a quarter of the population. Layer on top of that the pressures that make mental strain worse, like poverty, conflict, displacement, and health systems stretched thin. Mental health became the challenge nobody had the resources to face, and the shortage of specialists is almost hard to believe. In several countries, there is roughly one psychiatrist for every million people. In one large nation of over 200 million, there are only a few hundred psychiatrists total. Do the math and you see the problem. You could never train enough specialists fast enough to close a gap that size. If the answer was going to be more psychiatrists in more hospitals, it was never going to arrive. So people stopped waiting for that answer and started inventing a different one. For a long time, mental health care meant one thing: a big psychiatric hospital, usually in a capital city, usually far away. If you lived in a rural area where most people actually live, that hospital might as well have been on the moon. So the big idea driving the quiet revolution is beautifully simple. Stop making people travel to the care. Bring the care to the people. Here is the clever part. Instead of relying only on scarce specialists, countries began training regular community health workers, people already living in and trusted by their communities, to recognize common conditions like depression and anxiety, offer basic support, and refer the serious cases onward. It is sometimes called task sharing, and it flips the whole model. You do not need a psychiatrist on every corner. You need a well-trained, well-supported network of ordinary people who know what to look for. This is the model that international guidance has pushed for years. A step system where the front line is your neighbor, the middle is your local clinic, and the specialist hospital is reserved for the cases that truly need it. And when it is done well, it reaches people who were never going to be reached any other way. So let's get specific because this isn't theory. Around the region, real programs are showing what is possible. Here are 4 of the most exciting. The first is almost disarmingly humble: a bench. A trained community worker, often a respected local grandmother, sits on the bench offering structured talk therapy. No clinic, no waiting list, and no stigma, just a conversation that follows a proven method. Studies have found it genuinely reduces symptoms of anxiety and depression. A bench is cheap, it scales, and it treats people with dignity. Who knew a bench could make such a difference? The second idea is about reach. Ethiopia built a national army of health extension workers who bring basic services into rural communities. They spot early warning signs, offer first-line help, and connect people to the next level of care before a crisis hits. Folding mental health into an existing community health program allowed scale without new hospitals. The third tackles the money problem head-on. In Rwanda, mental health care was folded into the community-based health insurance that covers most people. When care is included in coverage, the financial wall that stops many from seeking help starts to come down. More people actually walk through the door. The fourth has the most room to grow your phone. Mobile tools deliver mental health education, self-help resources, and telecounseling to people far from any clinic. One app in Ghana can connect a user in distress straight to the nearest community mental health nurse. When a phone can carry support across 100 kilometers in a second, geography stops being destiny. It is early and it is not a magic wand, but the promise is enormous. Now, this would not be policy talk if we did not tell you the honest half. These wins are real, but the obstacles are serious, and pretending otherwise helps no one. Start with money. In many countries, mental health receives less than 1% of the health budget. That single number explains a lot. Too few staff, unreliable medication supplies, and programs that stall before they scale. There is also brain drain, as some trained specialists leave for better paid work abroad, thinning an already thin workforce. Then there is stigma, maybe the quietest barrier of all. In many communities, mental illness is misunderstood as a personal failing or a spiritual affliction, which keeps people silent and isolated. Often the first person someone turns to is a traditional healer, not a clinic. Rather than fight that, some programs in Uganda and Rwanda work with traditional healers, training them to recognize serious cases and refer people onward. Meet people where they are, and you build trust instead of walls. And finally, geography again. Too often, good services cluster in big cities, while rural areas where most people live get left behind. Closing that gap is the whole game, which is exactly why community-based mobile-powered ideas matter so much. So what does the path forward actually look like? It comes down to 5 moves, and none of them require waiting a generation. 1. Fund it properly. Mental health can't keep surviving on the scraps of the budget. Even modest, steady investment buys medication, staff, and infrastructure. 2. Keep training the front line, not just specialists, the vast network of community workers who can carry the load closest to home. 3. Weave mental health into regular primary care, so a checkup for your body is also a check-in for your mind. 4. Lean into technology, telecounseling and mobile tools that reach the isolated and support workers with training on the go. And 5. Keep talking about it. Public campaigns, community support groups, and honest conversations that chip away at the shame. Every open conversation makes the next person's easier. Here's the hopeful truth we started with. The mental health gap is huge, but it is not permanent. A bench under a tree, a trained neighbor, a phone signal reaching a village. These aren't fantasies, they're already happening and they're already helping. The revolution is quiet, but it's real. If you or someone you know is struggling, please reach out to a mental health professional or a support line in your area. We've put some resources in the description. What's one thing your community could do to make talking about mental health easier? Tell us in the comments, we read them, and the best ideas shape future videos. If this gave you a bit of hope, hit that like button. It genuinely helps the channel grow, and subscribe so you don't miss the next deep dive. Until next time, this is Policy Talk, making policy make sense.